Welcome to the class. The next chapter we are going to discuss is disaster management. What you have in front of you on your slides is the management sequence of a sudden onset disaster. We will start from the disaster impact, and which is followed by a prompt response, which is after some time goes into the phase of rehabilitation, then reconstruction. After reconstruction we have disaster mitigation, and we enter into the phase of disaster preparedness. So this is the disaster cycle, and this is how disaster occurs. So when you have a disaster, you have a response followed by rehabilitation, reconstruction. After reconstruction we go into the phase of disaster mitigation, and you should not forget that the disaster ever occurred at the first place, and therefore you have something called as the disaster preparedness. So be prepared for the disaster, because they don't tell you that they are coming, and therefore disaster preparedness is important until you have the next disaster. So this is basically the disaster cycle. As you can see, the first phase after the disaster has been called as the recovery phase, and the next phases are called as the risk reduction phases before the disaster. Risk reduction phases have basically an aim to reduce or minimize the effect caused by the disaster. Say if you are living in a earthquake prone zone, making an earthquake proof building would be the most logical thing to do. When you have earthquakes, you have falling buildings. If the earthquake happens during the day, you have skull fractures and hand fractures, which are very common. If the earthquake occurs at night, you have the rib fractures and vital injury trauma, which are very common. So these are the patterns of disasters, and you should prepare yourself accordingly. The definitions. The definition of disaster is any occurrence that causes damage, ecological disruption, loss of human lives, or deterioration of health and health services on a scale sufficient to warrant extraordinary response from outside the community. So the important part here is extraordinary response from outside the community. Disaster is on such a large scale that the native community cannot help themselves, they cannot support themselves, and therefore they need help from others. Earthquakes, tsunamis, fires, all these are kinds of examples of disaster wherein external support is required, and therefore they qualify for being called as disasters. What is, on the contrary, an hazard? A hazard is a phenomenon that has a potential to cause disruption or damage to people and their environment. So a thing, an event or a phenomenon which has got a potential to cause disruption of damage to people is called as a hazard. We just discussed biomedical waste, so that was a hazard. It had a potential to cause damage to the general public, and we therefore say, let us not let the waste of the sick make the healthy ill. So hazard is that sort of thing which has a propensity to make others ill or to cause damage. So to put it in context, disaster is the event, hazard is something which can cause a disaster. Examples of disaster, a long list. You have earthquakes, cyclones, floods, tidal waves, landslides, volcanic eruptions, tornadoes, fires, hurricanes on one side, and on the other hand you have snowstorms, heavy air pollution causing smog, heat waves, famines, epidemics, building collapses, toxicological accidents, nuclear accidents, and warfare. Now the last one on that list, warfare, is a special category altogether, because in warfare damage is the intended outcome. So it is a special category of hazard in which damage, maximum damage, is the intended outcome. We don't bomb another countries just to have some firecrackers. So this is paradoxical. An example where damage is the intended purpose. The others, like I told you, earthquakes, you have most damage when the earthquakes occur at night, because people don't get time to respond. Many people get impacted below the houses, and therefore they can do very little to save themselves. So mortality tends to be higher in night. Cyclones, usually cyclones and tornadoes would not cause much of damage, at least for life. The property damage are very, very high. Floods, again, if they occur at night, they can be very devastating. And tidal waves don't cause much damage unless they are associated with tsunamis. Tsunamis are, I hope everybody knows, those big walls of water crashing onto cities. So unless those tsunamis occur, tidal waves by themselves don't cause much of a life harm. Volcanic eruptions, again you have well delineated volcanic zones and people know that they are living in a volcanic zone. So if you are living in a volcanic zone, prepare accordingly. Having said that, we also acknowledge that volcanoes are not always recorded. You might have a sudden volcanic eruption which was not expected or which was not documented. Morbidities due to these hazards or these disasters. You can have injuries, emotional stress, disease epidemics and increase in indigenous cases of the disease. Injuries are obvious. If you have a disaster, there are many injuries. Emotional stress, something called as post-traumatic stress disorder. If you have recurrent thoughts of that disaster, you can't rest, you are very anxious, a pin drop causes you anxiety, you are reminded of maybe a bomb blast that you saw, that is post-traumatic stress disorder. So when you are unable to go back to your routine life and a disaster disrupts your routine life, that is the emotional stress component. Disease epidemics, there can be a lot of reasons. First of all, your piped water supply is disrupted. You don't get your routine water, so you have to drink unhealthy water. People may immigrate or immigrate. So people may come to your place or they may leave your place. In which case, if they have a disease which your community does not have, that disease might then start spreading to the native community. You also have disruption of a lot of ecological variables. Mosquito breeding pattern changes, and there are a lot of other fleas, dogs and other carriers of disease which may also come with a population, or you may go there, or because of them the native population of these flora and fauna itself changes. So therefore there can be 1,000 things which can go wrong as far as the disease balance is concerned, and there obviously can have increase of indigenous cases itself of the disease because of all these changes. Short-term morbidity, directly death, the building collapsed and death occurred. Severe injuries requiring extensive treatment is another category. Increased risk of communicable diseases, we saw how that can happen. Damage to healthcare facilities is a big problem. What happens usually after a disaster is that people rush to the healthcare facilities. Healthcare facilities are then the temples. It does not matter what kind of healthcare the healthcare facility was giving earlier. After a disaster, everybody comes to the healthcare center. Damage to the water systems, so you don't have your supply of purified water. You can have food storage, and there is, like we said, major population movement on the outskirts of the disaster zone. So the outskirts of the disaster zone becomes the new high risk area. Disaster management stages, we have 3 stages. Please remember them. Questions are asked. You can have a simple MCQ as which of the following is not a disaster management stage. So the disaster management stages are, the first thing we saw, disaster response. Obviously a disaster has occurred, we have to have a response to that disaster. The second thing you have to do is disaster preparedness, and then you have disaster mitigation. So these are the stages of disaster response. Coming to disaster impact and response, it is divided into search and rescue, first aid, triage, stabilization of victims, hospital treatment, and redistribution of patients to other hospitals. So these are the steps which are to be done under the disaster impact and response category. First step is search, rescue and first aid. You will have to have, obviously, to give first aid at the time of impact, at the place of impact. So first aid and rescue is very important. Provisions of food and shelter have to be made, because many a times the shelters are destroyed, so you will have to arrange for temporary shelters, blankets, pillows, stuff like that. Victim identification has to be done very rapidly. Most of the time, try that people who are ambulatory or who can be treated at the periphery do not come to the healthcare facility, because the healthcare facility in all probability is expected to be overwhelmed, and therefore they should be treated peripherally. There should be provision of adequate mortuary spaces, because if the disaster is a big one, you have a big tsunami or a big wildfire, a volcano or something on a very large scale, then the number of deaths are expected to be very high. You have an important topic here, that is triage, and triage comes again under impact and response. So what is triage, why we do it, how we do it, we are going to see. And if you have to bet your penny on this chapter, I would suggest you that you bet it on this triage. Many questions have appeared and they will appear, because again this is something substantive. So let us discuss triage. Triage is basically a method of classification of the people who need the treatment most, then who need treatment but not very severe, and then somebody who does not need treatment, who is ambulatory, who can be sent back home with a pat on his back, and somebody who is so much troubled and who is so much of mutilated, injured, bleeding, whatever, that he is already moribund and there is no chance that with the adequate level of, the available level of healthcare facility, he could be saved. So triage is, we don't have the first come first served basis. What we do is treat on the basis of the probability of the person surviving the event. Who does the triage? You are a doctor, you are a surgeon, you are posted at a hospital, you go to the periphery and start doing triage. If you do that, who is going to treat the patients at the hospital? So doctors or other healthcare functionaries are not supposed to do triage. Triage is supposed to be done somebody who is at the village level, village healthcare workers, and the people at the periphery should be trained for triage, so that people who can treat are not doing things like triage. With that, let us see triage. As I told, triage is not first come first treated philosophy which we routinely follow. If you have an OPD, people come to your OPD, this is the routine philosophy. I came first, my number is first, I'll have to be seen first. This is not done in triage. Consists of rapidly classifying the injured on the basis of severity of their injury and the likelihood of survival with prompt medical intervention. Please do not forget the second line, the likelihood of survival with prompt medical intervention. If you remember just the likelihood of the severity of injury, then somebody who is moribund should not be sent to the hospital, because the chances of him being saved at that point with the available medical services would be negligible. So the likelihood of him getting better at the available health facility is also considered. High priority is given to those whom immediate medical and long-term prognosis is good with treatment. Low priority, moribund requiring great attention, questionable benefit, are low priority, carried out at the site of disaster. Triage is not done at the hospital. It is, as I told you, done at the periphery. Peripheral health workers do it, and hospital is to be spared from doing triage at the time of a disaster. Minor or moderate injuries are treated at home. As I told you, don't want to overburden the hospitals. So anything that is minor, anything that is ambulatory can be taken care of peripherally, should be taken care of at that level. Seriously injured people are sent to the hospital. How do they get to the hospital? If you have a disaster, people come to the hospital with whatever they have. So they don't have an ambulance, they come on a cycle, they come on a rickshaw, auto rickshaw. So whatever and everything that moves basically is converted into an ambulance. You have a color-coded system for triage, and the most accepted system is the 4-color system. Again, we have a very difficult classification here for triage. You would have a very hard time remembering that, and that is, you have 3 colors as you see on your slide: red, yellow and green. I bet you have never heard of these colors. Okay, so it is very easy: red, yellow and green. Red is danger, yellow is okay, and green is very fine, is very good. It is very simple. The last category which is just added is the black one, so that you need to remember separately. Black is either the patient is dead or he is in grave danger of dying, so therefore he is tagged as black. He is alive, but there is questionable benefit how much he will get better with treatment, or he is almost on the verge of death. That is the black category. Red category is high priority treatment for transfer. Say somebody has got a fracture, he is bleeding. If he gets to the hospital, the bleeding is stopped. You can set the fracture later, but he will be saved. So those kinds of injuries which are high priority should be tagged as red. Yellow is the medium priority, and green ones are the ambulatory patients, few stitches or dressing, things like that. So you just apply your common antiseptic lotion to the person, he has got some scratch and he goes away. So that is green. So that is the classification, very simple, nothing much to be confused here. Just remember, black is a new category, otherwise the red, yellow and green are as routine. Black says almost dead. Tagging of the patients is another function to be done in a disaster scenario at the periphery, and the tag should contain the name of the patient, the age of the patient, the origin, where does he come from, TRIAGE category that we just discussed, the diagnosis of the patient and initial treatment. So these are the information that should be available on the tag. Identification of the dead. This is a delicate issue. You have to identify the dead, you have to provide adequate mortuary space, you will also have to arrange for the lot of people who are going to come to the healthcare facility for taking the relative's dead body or knowing if their relative is dead or alive. So that is identification of the dead. Respect to dead is important. Sometimes dead bodies are thrown carelessly and that can cause a lot of emotional anger and frustration with the public. Dead bodies, if they are thrown indiscriminately, can go into wells or rivers and streams and can cause gastroenteritis and other diseases. So they may contaminate wells and streams and can cause gastroenteritis or food poisoning. Care of the dead include removal, shifting to the mortuary, identification of the dead would be very important then, and reception of the bereaved relatives. So these are the functions under management of or what to do with the dead. Relief phase. We move on. Next phase is relief phase. It is determined by the type of the disaster and the type of supply available. So relief phase, obviously, what kind of disaster are we talking about? Relief phase depends upon that. Treating casualties and preventing spread of communicable diseases is very important. As we just discussed, restoration of water supply would be very important. Food hygiene would be very important. Prevention of communicable diseases, very important. So these are the public health measures which should be rapidly instituted, and rapid damage assessment is needed. So what is the damage to the hospitals, the healthcare facilities, how many healthcare personnel are available, what are they doing? All these analysis is done in the relief phase. Relief, 4 principal components are there in the relief phase. First is acquisition of supplies, including food, blankets, clothing, shelter, sanitary engineering supplies, construction material, and practically a lot of other things. Again, depending upon what type of disaster are you talking about, a lot of supplies come. Disaster managers should be ready to accept huge amounts of helps coming in, because if it is an overwhelming disaster like we saw with tsunami, the donations tend to be very, very high, both in terms of monetary, cash and kind. So you have huge amounts of blankets coming in, mattresses, huge money, food, and all other sorts of remedies. So acquisition of supplies is very important. Transportation of these supplies to the needy. You can see those, imagine the helicopter dropping food packets to children who are running underground. Storage of these supplies, otherwise everything goes bad. Say if you have a packet of biscuit which is not stored properly, then it is simply inedible after a couple of days. And distribution of these supplies to the needy. So these are the 4 principal components of the relief phase: acquisition, transportation, storage, and ultimately distribution. Epidemiological surveillance and disease control mechanisms. What are they? You have overcrowding and poor sanitation resulting in ARI. ARI is acute respiratory infections. So overcrowding and poor sanitation contribute to ARI. Population movements can lead to spread of communicable diseases. Notably, you can have tuberculosis, leprosy, cholera, typhoid, some of the diseases which can rapidly spread. Disruption and contamination of water supplies and damage to sewerage and power systems. So there are power outages, sewerage systems are disrupted, and so are water supplies. Many times when reconnections are done, few of the sewerage pipes can get reattached with the water supply, and the water supply gets contaminated directly with the sewage. This can happen and can lead to very big epidemics. Water supplies, when we talk, there are two types of water supplies: single water supply and double water supply. Single is when you have just one type of water coming in for all your uses, and dual is when you have your pure water or chlorinated disinfected water for one tap, and you have the undisinfected or not disinfected water in the other tap. This was an experiment done in India which failed very pathetically. When the dual water supply system was introduced, many a times those taps were interconnected and the pure water got mixed with impure water. What also frequently happens is this that I just told you: sewerage pipes are connected to drinking water pipes, and then you have the sewerage which is flowing into water and the water gets contaminated. So this happens, and in a case of disaster, you can imagine this can happen on a very large scale. So if you are asked in the examination about dual water supply, not a good idea. It is a good idea in theory, but in practice it does not work. Disruption of routine immunization programs you have. So we talked about those deadly diseases, vaccine preventable, including the measles. Those get a chance to multiply because now vaccinations are not working. There is a collection of susceptible population. There is inflow of other population. Maybe some of them have the disease. They can introduce, herd immunity goes down, and there is a disease outbreak. Zoonosis, especially leptospirosis during floods, should be suspected. Now, leptospirosis is a disease which has somehow come to be associated with floods. If the question mentions floods, leptospirosis is the disease. Okay, so leptospirosis after floods, it is common. Food and water may be new source of infectious diseases. You get new food, maybe the packaged food is not good. You have botulinum in them, staphylococci, streptococci, who knows. The food is not good, the water that you are getting is not disinfected, and they themselves can be a source of disease. With that, we complete the first part of this chapter, and we'll be seeing the second part in the next class. Thank you.